Welcome back, and now we're going to discuss part 2. So fast track to 3 weeks later, and the patient was given the following protocol: amoxicillin starting 1 day before and for 4 days afterwards. And I will put the list of the detailed doses and the medications that we gave in the description below. The second was 5 milligrams of diazepam the evening before the procedure, and then a further 5 milligram tablets 1 hour before the procedure. We gave the patient chlorhexidine diglutinate mouthwash to be used only on the 4th day post-surgery. And to manage pain and swelling, we gave the patient ibuprofen and paracetamol. And finally, the patient was given probiotics, which is a standard protocol in my surgery whenever we give patients antibiotics. So let's dive into this case. So this is on the day of surgery, and the patient's pre-operative vitals, his blood pressure was 173/94, and I highly recommend that you always do that on your patients. His pulse rate was 83, and his oxygen saturation was 98, so he was in a good state to have local surgery. We anesthetized the patient both buccally and palatally with Lignospan Special 4 cartridges, and I used the custom surgical guide for the osteotomy preparation. This is a picture of the flap design. So we made a incision, not a crestal incision, but a more palatally aligned incision, starting distal to the 1/4 and running on the palatal side posterior. This was done as a conscious decision. Normally, I would take these cases even further, both on the palatal and on the buccal, but we were using this as a training case. I had a clinician that I was teaching at the same time how to do this, and we used different incision technique to show him a couple of other things, which I will show you in a minute. The one thing that we also did prior to lifting this flap is we put the surgical guide in this area, and I drilled a pilot hole through the gum in this area. So this is the picture of the open flap, and we had to extend far back because we needed to access the exostosis that we were going to harvest the bone from to use in our sinus lift procedure. This gave me an opportunity to remind the patient another time, and I actually showed him with the mirror that he still had not gone back to his dentist to repair the missing composite distal to this 1/4. So the first thing on the shopping list, which I cracked on with immediately, is using my piezoelectrical, and we harvested the exostosis that was lying on the buccal of the 1/7 site. It almost looked like a little small tooth, but it was entirely bone. And we managed to harvest the exostosis. Here you can see it. And what we then did with this piece of autogenous bone is that we broke it into several smaller pieces, which we then mixed with BioOs, which I will show you in a few minutes. The next step was we drilled the pilot hole a little bit deeper, and we placed very carefully, we placed a direction indicator into the pilot hole, and then with the piezoelectrical, we very carefully opened a round window. This gave me the orientation to be able to design and to open the window in exactly the right area to facilitate the sinus lift. One thing that is important, which is, and I want to emphasize this, I would normally, under normal circumstances, make the relieving incision between the 1/4 and the 1/5. In this particular case, we did a distal to the 1/5 because I was trying to show the clinician that I was teaching how important it was to always be able to have enough distance between the distal of the incision line and the sinus lift. You don't want the incision line to be directly above the sinus lift area when it heals. You want a little bit more gingiva in that area. And there's no way better than to show it in situ when you're doing a procedure like this. So this is the right side view of once we'd finished doing the aperture to the sinus lift, and we can see the intact Schneiderian membrane just below that, and there was still more than enough space between the incision line and the window to go into the sinus, and this is the point that I was trying to emphasize earlier on. However, Once again, I prefer this to be lifted even further up to have much more coverage over the sinus area. So to pack the sinus, the plan was to mix a bit of autogenous bone. Here is the exostosis that we had broken up into a few little pieces with a little bit of bios. And these two were mixed. And what I always like to do, if possible, is to collect some additional bone whilst doing the preparation, and also to mix this with a little bit of blood, because especially if it's blood from the bone, because that carries all the genetic information. So when you mix these two, it gives you the best possible outcome. Now we obviously know that when you're doing a sinus lift, because of the magic of the Schneiderian membrane and how much genetic information it carries in order to be able to allow bone growth, you can just about put anything inside there, and so even the weakest quality of bone can be placed into a sinus lift and you'll get a really good outcome. But obviously when you can, you always try and give the best and highest quality bone, and there's nothing like the gold standard, which is autogenous. So the next step is quite a crucial and important step, which is we then proceeded very carefully to place the implant in the 1/6 site. However, at the same time, with hand instruments, we had previously removed the Schneiderian membrane and protected the Schneiderian membrane from the implant that was being placed. And that is why it's important to have a large enough window to be able to see what you're doing and to be able to see the apical part of the implant as it's being placed in the patient's mouth, to ensure that there's no damage to the Schneiderian membrane. And the trick always when lifting and displacing the Schneiderian membrane from the floor of the sinus is to work with very sharp instruments, to work very carefully and methodically, and to remove the membrane around and to create enough of a pocket in this area for then us to be able to carefully see as we are placing the implant, and also then to be able to pack this area with bone. This picture was taken with the 1/6 osteotomy site already prepared, and we confirmed the intact Schneiderian membrane, which we can see here. And as the patient breathes in and out, you'll actually see this membrane popping in and out slowly. That's always a very good sign. We then very carefully placed a resorbable membrane between the Schneiderian membrane and the gap created for the placement of the bone graft. One of the critical points is whenever we place membranes, to make sure that the edges of the membrane are round. We don't want any square or sharp edges, even if the membranes are very soft and smooth. Here is another view of the membrane covering the Schneiderian membrane with the gap that's been left behind. We then very carefully place the implant in situ whilst observing the sinus through the window that we'd created. We used very low torque, and we were able to place the implant, which torqued out at 35 Newton centimeters, and I was delighted with the technical outcome. This bone was high quality, and so I was able to drill to 4.5 millimeters in diameter, but I placed a 5 millimeter diameter implant, which gave me good primary stability. And this is a picture of the 1/6 implant in position with the open window. We had already packed a little bit of bios material in that area. We then very carefully, with an instrument, placed bios into the window that we'd created for the sinus lift. It is important when pushing materials into the sinus that we make sure that all this little kind of debris that is left behind is picked up and suctioned and cleaned, so that we don't have any of these little pieces lying around, because they then tend to create little problems afterwards. Once I'd packed sufficient bios mixed with a little bit of blood into the sinus, what we then did was we covered the sinus lift with a little bit of autogenous bone that we had used from the harvest site further back here in the mouth. We then placed the implant into the forceps site, and whilst I prepared this implant, same thing, all the little bits of bone that I was able to collect whilst preparing the osteotomy site in the forceps site, we kept that and packed that on the outside of the sinus fenestration to be able to pack it nicely closed. And we can see both implants in position already. And so finally, a resorbable membrane was packed over the sinus window, and this area was then very carefully sutured closed. And here's a photograph of the wound closure with the sutures in position, and we used a combination of 4O polysorb and 3O vicryl sutures. This is the right side view, and let me show you the occlusal view. And here's a picture of the occlusal view with the full wound closure, which is paramount to allow this area then to heal nicely. And that went very smoothly. That took us half an hour to do that procedure from start to finish. The patient was given some very detailed instructions in terms of what he couldn't do. One of the things that I tell my patients not to do under any circumstances for 6 weeks, and 6 weeks is quite a long time, but under no circumstances are they to blow their nose, and if they're going to cough, they must cough freely. They mustn't try and hold back the cough. If they were going to blow their nose, I actually show them, get a little tissue paper and just very gently to clean their nose. We don't want any kind of damage to that sinus. I also tell my patients that 99% of them will get bruising after the procedure, which is common. And in truth, only about 1/3 of them get that. And if they're the ones that don't get the bruising, they think you're an excellent surgeon. Finally, the patient was going to go back to Mexico for a few months to visit his family, and he made an appointment to return to us 5 months later.